Yeah. Prabha, shall we start?
Yes.
Go ahead.
Wait for 2 minutes or we'll start right away.
I think there are participants, so
Yeah.
32 attendees are there. We can start.
We'll start.
Hmm.
Good evening, one and all. So, welcome to the second meeting of the IAN Stoke subsection. I'll request Dr. Satish Kumar, who's the convener, to proceed to further take over the proceedings.
Okay. So good evening, everyone. It's pleasure to be here. Welcome, Dr. Prabhas, the chair of Indian Academy of Neurology. Greetings from our president, Dr. Lakshmi Narasimhan, as well as the IAN secretary, Dr. U. Meenakshi Sundaram, sir. With their guidance and the new president-elect, Dr. Sudhar Kothari, sir, we will be continuously going on with the coming online as well as the physical platforms for the Indian Academy of Neurology stroke subsection. So this is second on the line, and we will be happy to welcome Dr. Baishak. Welcome, Baishak. So with a brief introduction, so he is currently the MD, DNB, MRCP in neurology. He's a consultant neurologist with over 8 years of experience. He got his DM neurology from Government Medical College Trivandrum, as well as he has done his DNB and MRCP from Royal College of Physicians, UK. So his special area of expertise is in stroke, and acute stroke care and thrombolysis and neurocritical care. He has vast experience in managing cognitive neurology, movement disorders, as well as a lot of clinical academic teachings. To his credit, he is the national faculty for Marrow Super Specialty Training Programs, mentoring a lot of postgraduate students across India. And he has the best outgoing student during his MD General Medicine at uh, Government Medical College, Mysore. And he has a lot of publications to his credit. So over to you, Dr. Baishak, and he will be talking about the acute stroke management guidelines, which has been recently published in 2026. And he is going to give a critical appraisal from minutes to midnights. That is from whether the first 24 hours after the post onset of stroke, how do we manage this acute stroke as per the guidelines, and as well as his viewpoints. And we can take the questions and queries at the end. And the panel is open to all. You can ask questions in the chat box or raise your hand and ask questions if you want to interrupt Dr. Baishak in between. Over to you, Dr. Baishak.
Thank you, sir, for this. Thank you, IAN Chair Prabhas sir and Satish sir and IAN Stroke Subsession to give me this opportunity. So I'll be discussing basically. I'm Dr. Baishak Renuji. I'm a consultant neurologist in MIC Medical College, Kochi, Kolanjeri. So I'll be discussing basically from minutes to midnight. So basically the recent updates which happened in the 2026 ACHA guidelines. And like if you look in the studies of the trials of thrombolysis, it started in 1995 NINS trial, where it was 3 hours was the window for thrombolysis. Approval for Altiplase we got in 1996. If you see by 12 years or 13 years, by 2008, the window was extended to 4.5 hours. Till that we were discussing about 4.5 hours. Then multiple studies came during the period, but the window was still 4.5 hours. The change happened when Epithet trial in 2008 came. They put forward the perfusion imaging. Then came the wake-up trial, a new treatment option for the wake-up stroke, which we were not treating previously, by using MRI-based protocol, where we were timing the onset. We were not actually looking at the tissue, we were looking at the time of the onset by using MRI diffusion flare mismatch in 2018. Then you can see by 2019-20, the extend trial, ICAS-4 trial, which came. And now, which was there previously 3 hours or minutes, it's slowly shifting its time limit from 4.5 hours to 9 hours by using perfusion analysis. Then came the TNK era in 2022. Then tenelteplase became easily available, which changed the treatment of stroke because we can easily give it and single bolus. Then came the timeless and trace trial in 2024. The trace trial basically is they look into the LVO, even the LVO up to 24 hours, whether you can lyse. So it is slowly a shift from minutes to a 24-hour window. That change the thrombolysis window you can visualize from how the studies is progressing from 1995 to 2024. So I'll be discussing very practical aspect. We'll not be going into the EMS management, stroke unit setup, all those things. So when you see a stroke, the first thing you obviously will do is assessing the patient, having an NIH score, and maybe doing a GRBS. But after that, the question will be imaging and selection stroke. So I'll be going in these 6 areas. Basically, first I will deal image selection stroke. Then what changes has happened in the general management. Then what are the contraindication of lysis? There are a lot of changes happened in the contraindication. Many of the contraindication which previously thought are now not a contraindication. Then we will discuss about thrombolysis, what is new in thrombolysis, and extended window lysis, where a lot of things happen. We have extended window even up to 24 hours in certain scenarios. Then we will look into EVT. So first we will start with imaging selection in stroke. So imaging selection in stroke, you can divide into 2 aspects. One, imaging selection lysis, imaging selection for thrombectomy. So basically lysis, there is not much change in first look, but there are changes. So basically previously door to image time was 20 minutes. Now they had extended 5 minutes. Actually, this is for CT angios. So now the door to image is preferably 25 minutes, any image, either CT or MRI, depending upon your hospital protocol and depending upon how fast you can do that protocol, because stroke is a clinical diagnosis. Then if you suspect LVO, you should do a CTA or MRI, the angiographic image, which include the intracranial as well as a cervical vessel, should be covered in this angiographic image. This is almost same like what you have in previous guidelines. But the changes happened is 2026 guidelines, pediatric thrombolysis started. So pediatric thrombolysis is one area where MRI is preferred more than CT. Otherwise, CT or MRI, any investigation, whichever you can do in 25 minutes is better. In pediatric, there is a lot of overlaps happen. It can be seizure mistaken as stroke, and a lot of overlaps can happen. That is why MRI is preferred. But again, in pediatric, the problem is to take a MRI in a child, it may be difficult. So what they tell is MRI plus MRI is preferred in pediatric, but if you cannot do in 25 minutes, then you can do a CT angio and you can proceed with lysis. Then another thing is that we have anterior circulation aspects previously also. Now they started introducing posterior circulation aspects. So in PC aspects, basically they use in basilar artery occlusion for thrombectomy. So these are the major 4 changes. If you think it is pediatric, is basic change plus posterior circulation aspect, but there is one more entity. Previously in wake-up stroke, we were chasing the time. Like if you don't know exact onset, what you will doing is you will do an MRI and diffusion change is there, flare is not there. Then you time the stroke, but you are not looking into the tissue. So that was by we were doing only 4.5 hours window. Now the wake up and extended window, you can do in some scenarios up to 24 hours by using a perfusion scan. So that is a change which happened in the lysis imaging. Basically in pediatric, MRI is preferred. Posterior circulation aspects can be used. A wake up or extended window, you can additionally use a perfusion image outside 4.5 or classical window, which we'll discuss in detail when you come to the extended window protocol. So that is about the imaging in lysis. Then coming to EVT. EVT, again, first 6 hours, there is not much change. It is again CT angio. If you look into the old studies, old guideline 2019, where after 6-hour window, they use dawn and diffuse criteria. But currently, you can even manage a patient with the window of 6 hour to 24 hour with a CT angio or MR angio. You don't need an additional image. A perfusion image is not a must. So which also we will discuss later. So the emergent CT angio should be done in all MR or LVO within 24 hours, suspected LVO within 24 hours. But in 6 to 24 hour window also, the extended window of thrombectomy also, you can decide whether you need or not additional image. Usually you can manage even without additional image also. That is a major change because the previous guideline just based on dawn and diffuse. Then this is one more additional entity which is there. This is basically for a setting. They mentioned basically for a setting in UK and US where they have ambulance-based triage. So when the ambulance person is triaging the patient, you can use a new score known as the RAISE score. If the score is more than 4, or even if your NIH score is suggestive of a large vessel occlusion, or you clinically suspect of a large vessel occlusion, usually when you see such patient, you go to ER, take a CT and you lyse it, then shift to DSA. That can be avoided. The time can be saved by directly transferring such patients into the angiographic suite. That is known as DTAS. That is another change which happened in the imaging. So if a suspect LVO, you can directly shift such patients into angiographic suite and you can do a flat planar CT there, rule out bleed, lyse the patient. Then and there itself, you can take for DSA and do a thrombectomy if needed. So that will save a lot of time. So that is a new thing, that is a DTAS, direct triage to angiographic suite. It has 2B evidence, but still that is something which will change the management of stroke and reduce lot of time, wastage of time in the coming days. So basically, this is a RACE plus or rapid arterial occlusion evaluation score, which they suggest. Basically, it has 6 scores: facial palsy, arm motor, leg motor, gaze, aphasia, and agnosia. These are cortical signs. So suppose somebody has a facial palsy 1 point plus aphasia or any of the cortical sign, you will mark it as 1 plus. Or if any other cortical signs, you had to mark it as plus. Whenever plus is there, that is cortical involvement is there. So cortical involvement also suggests high probability of an LVO. So in suspected LVO, you can directly shift the patient to angiographic suite and do a DTAS, direct planar CT lysis followed by DSA. So the major changes happen in the imaging is door to image time is now 25 minutes. Any image can be done, but in pediatric, MRI is preferred. But if you cannot do MRI within 25 minutes, you can go with CT. All patients with LVO should get a CT angio irrespective of creatinine or MR angio. And a wake up and extend, you can lyse up to 24 hours, but in certain scenarios, but you should have a perfusion image. And EVT up to 24 hours, you can take without much additional imaging in most of scenarios, which also we'll discuss later. In DTAS is a new entity which has been introduced, where is a direct triage to angiographic suite for a suspected LVO. So these are the major changes that happened in the imaging. So these are the guidelines which they are given. So we have discussed about imaging in stroke. After imaging, you have decided now you should know what changes happen at general management. So basically, in general management, you assess airway, breathing, oxygenation, head position, blood pressure management, blood glucose, temperature. So changes which happened, I mentioned. So changes happened is basically oxygenation is one change which happened. So previously, what was the recommendation is you will give oxygen only if the saturation is less than 94%. But currently, what is the change is in a suspected LVO and anterior circulation LVO, and you are planning to take for thrombectomy, NIHS is between 10 to 20. NIHS 10 to 20, planning to take for thrombectomy, anterior circulation LVO, irrespective of baseline saturation, giving normobaric oxygen will help in better outcome at 3 months. 2B evidence. So that is one major change. In suspected LVO, you can give oxygen without monitoring, without looking at the saturation also. Even if saturation is normal, you can give. Head position, again, no change. There is no definite role of any head position. Blood pressure management, the cutoff is same. Like 185, 110, that is a cutoff prior to lysis. But post lysis, we had a tendency to keep a much lower blood pressure previously. Like you may keep 120, 130 to prevent lysis, prevent bleed. So that is now not advised. Post lysis, a BP less than 140 is no benefit. And post EVT, successful EVT, keeping a BP less than 140 is harmful. So basically, the cutoff should be 140 to 180 in a patient post lysis, post EVT. Then the third change has happened is in blood sugar management, the cutoff range should be maintained is ideal is around 140 to 180. But an aggressive control by using insulin to keep an RBS to 80 to 130 is not recommended. So these are the 3 major changes which happen in the general measures. Oxygen supplementation can be given to LVO. Post-lysis EVT less than 140, no benefit. And post-EVT less than 140 BP is harmful. And insulin to maintain aggressive control is not required. So these are the guideline change which happened in the blood pressure and general management. So we had finished imaging. We discussed about imaging. We had taken imaging. We looked into general management. Now we are going to look into contraindication for lysis. There are a lot of changes happen in the contraindication for lysis. There are some gray areas because many of the you remember the huge list of contraindication, 10 or 15 or 17 items were there previously. Now they had been changed a lot. Now these 10 things are the absolute contraindication. What I remember this is 3 related to CT, 3 related to neurosurgery, 3 related to general medicine stuff, and 1 is amyloid related imaging abnormality, which is a new entity. So 3 related to CT are CT with hemorrhage, absolute contraindication. CT with intraaxial neoplasm, absolute contraindication. Extraaxial mass like a meningioma, schwannoma, all those things are never a contraindication. Then a CT with extensive hypotensity. There is a catch in that. Because previously we call that if a CT is showing a large MCA territory infarct, now that is not what they meant by extensive hypotensity. Extensive hypotensity, this is the definition what they give. It's a clear hypotensity, and this hypotensity should explain the patient's symptom. Suppose patient right side weakness, on imaging there is an old infarct in the right side, that doesn't matter. the infarct or the hypodensity you see should explain the symptom. And that hypodensity is denser than contralateral normal white matter. Then that is already evolved infarct. There is no role in lysis. So the extensive hypodensity definition is if the symptom is explained by hypodensity and that hypodensity is more denser than opposite side contralateral normal white matter, then you consider as extensive hypodensity. So 3 with CT with hemorrhage, CT showing extensive hypodensity, CT showing intra-axial neoplasms. Then 3 things related to neurosurgery. One is a moderate to severe TBA, traumatic brain injury, within 2 weeks. A neurosurgery within 2 weeks. A spinal cord injury within 3 months. So 3 CT, 3 with neurosurgery, 3 with general medicine or something related to medicine, like a coagulopathy or thrombocytopenia, infective endocarditis, aortic artery resection, and the last one is amyloid-related imaging abnormality. So these 10 things are absolute contraindication. Remaining everything is not an absolute contraindication. So previously we call recent stroke, old ICH, these are not absolute contraindication now. So there are some gray areas in this, especially in Indian scenario, which we'll discuss later. So the moderate to severe TBA, also they give a definition. If the TBA was associated with unconsciousness more than 30 minutes, or a GCS score less than 13, or there was a hemorrhage contusion skull fracture in the previous TBA. So that is a contraindication for thrombolysis. So the old contraindication has changed. There are only 10 contraindication, 3 with CT, 3 with neurosurgery, 3 with general medicine stuff, and 1 is amyloid-related imaging abnormalities. So that was the absolute contraindication. So whatever we thought previously, the old ischemic stroke or recent ischemic stroke or prior ICH, these go into a relative contraindication. So pre-existing disability and frailty is never an absolute contraindication. All these relative stuff, you have to take individualist approach. And DOACs or NOAC usage within 48 hours is not an absolute contraindication. If you have the facility to do the particular testing and reversible agents are there, then well and fine. But in Indian scenario, majority of the places, this is going to be an absolute contraindication actually. Then coming to ischemic stroke within 3 months and prior ICH. So these are 2 difficult areas to decide. So what they mention and what is a practical approach is, if the previous stroke is very small core, non-disabling, complete or near complete recovery, and the present stroke is disabling, and imaging shows no hemorrhagic transformation, then you can consider. Again, you have to make sure that this is not the same territory. Suppose somebody has a internal capsule or capsule ganglionic area, small infarct. After 5 days or 7 days, they can have worsening. When you do an MRI, you may see the same infarct which has expanded. So that you cannot take for lysis. It should be, the previous should be different territory and it cannot explain the present findings. And this is a small core, non-disabling, near complete or complete recovery. And the sizable infarct is not there. Sometimes right hemispheric PCA territory or MCA PCA watershed infarct may not be producing that much symptoms. But if maybe very large infarct. So sizable infarct, even if it is less than 3 months, it is better not to take. So that is what is practically possible. So a prior ischemic stroke, if it is a previous insult, is small core, complete recovery, near complete recovery, you can consider, provided these things are met. Prior ICH, which is again a difficult scenario to decide. So some practical point is, if that prior ICH was because of a non-correctable cause, like a cerebral amyloid angiopathy, you better avoid it. Don't lyse. Unknown cases also be careful because it might not have been evaluated fully. Then very recent ICH, maybe 2 weeks, 3 weeks, better not to take. And MRI may add on to help. If you do an MRI in such scenario, if you see multiple cortical microbleeds, more than 10, then also you may have to rethink. And also you can look into the whether the old bleed is having a hemostidin large cavity with fragile vessels, better not to take. So these are some things you can practically approach. So basically, those with prior ischemic stroke and prior ICH, that is not an absolute contraindication. You have to weigh the risk benefit, then discuss and then decide. Again, difficult scenario, especially in Indian scenario where the patient may come without any prior imaging. Patient come to a new hospital. Again, difficult scenario, Indian scenario. But if you have the prior imaging, prior reports, it is well. Then surgery within 10 days, outside 10 days is never a contraindication. Less than 10 days or neurosurgery outside 2 weeks, because within 2 weeks is always contraindication. Moderate to severe TBA outside 2 weeks. These you have to take consultation from corresponding surgeon or neurosurgeon to decide whether you should go ahead or not. Again, it is a benefit versus risk. Unruptured AVMs or intraocular dissection is never a contraindication now. Recent MI, less than 3 months. a pericarditis, cardiac thrombus. These are situations where you have to discuss with your cardiologist. And recent GU bleed within 3 weeks. Again, it's not an absolute contraindication. Again, if it is active bleed, you cannot lyse. Again, they tell to discuss with the gastroenterologist, risk versus benefit you have to consider. Active malignancy, pregnancy and postpartum, again, it is not an absolute contraindication. If it is severe stroke and the risk is less, benefit is more, you can decide. Again, have to cross consultation with corresponding specialty. A dural or non-compressive arterial stick within 7 days. Again, you have to decide whether this may be dangerous or not. So basically, this, at least you remember the 10 major contraindications. Remaining things are relative, where you have to weigh the patient depending upon the patient age, disability, and what will happen, the risk. Have to discuss and have a cross consultation. One major issue you're going to face with recent MA, because the recent MA, if it is very recent, it may be very difficult to take. So it is like 1 or 2 days or few days. It's better not to touch. But again, you can follow the previous guidelines. A recent MA, if it is an STEMI or a STEMI of right or inferior wall, the 2019 guidelines it is reasonable, 2A. So such may not be that much problem, but you have to take a cautious and take an opinion when it is a left myocardial STEMI. So it is a STEMI, it's okay, fine. STEMI of right or inferior wall, also fine. But STEMI of left myocardium, be careful, because they can have a cardiac tamponade and ventricular rupture. If it is extensive MA, if you're taking within recent MA within 3 months. So such scenario, you need to take an opinion from cardiologist. Again, it is going to be difficult in a rural center. So this is a relative contraindication and absolute contraindication. Then you see the definite benefit is there. Extracranial dissection, cervical IC or vertebral dissection, not a contraindication. Intracranial carries mild risk of increased risk of bleed. Extraxial neoplasm, not a contraindication. Unruptured aneurysm, previously aneurysm size less than 10 was 2A, other more than 10 was difficult to take. But now unruptured aneurysms is not an absolute contraindication. Old history of MI, old history of GA-GU bleed, Moya disease carries mild risk of bleed in adult, but they are telling you can take it for lysis. Stroke mimics can be lysed. That is there in previously also. In conversions and all, stroke mimics, the chance of bleed is less than 1%. They tell in the guidelines that is around 0.5% or even less than that. So stroke mimics can be lysed, they come in the window. So one more thing they are not mentioning in the contraindication, but they are mentioned in the guidelines is cortical microbleeds. Cortical microbleeds, the patient doesn't know, the patient doesn't have unknown cortical microbleeds. You can lyse, no need to go for MR or nothing. But if there is already non-cortical microbleeds and it is more than 10, the usefulness is uncertain and there is a risk of bleed. And again, the location matters. The cortical, the superficial siderosis, these carry slightly more risk, but studies are very less. So what you can tell is more than 10 is not an absolute contraindication, but you have to rethink. So these are the contraindications. So at least remember the major contraindication: 3 with CT, 3 with neurosurgery, 3 with general medicine, 1 with ARIA, amyloid-related imaging abnormality, where you treat the Alzheimer's with the newer modality of treatments. So that was about the contraindication. So we covered imaging, we covered general management, we covered contraindication. Now we are going to thrombolysis. So thrombolysis, basically, the major change is you are not looking into NIHS, you are not looking into aspects. What you're going to do is, if it is disabling, no other contraindication, lyse the patient, if that is presenting in within window. So that is a major change. Even the previous guidelines, if you look, they also tell that minor stroke, disabling, lyse. But disabling minor stroke definition was not clear. Now they had given a definition for disabling minor stroke based on PRISM's trial. But this definition again practically have some difficulty, which we'll discuss. Penalty place in previous guidelines was 0.4 milligram and 0.25 milligram. 2 doses were mentioned, and the level of evidence is 2B. But the current evidence is much better. Penalty place is equivalent to altiplace. Level 1 evidence, even up to 4.4 window. And the dose is regularized to 0.25 milligram per kg. Maximum 25 milligram. Then other thrombolytics are discussed, like retiplase, pro-urokinase. This has been discussed now. Even got approval with level 2B evidence. And pediatric thrombolysis is there, but you have to make sure that pediatric thrombolysis, the recommendation is to use altiplase, not tenalteplase, because studies are less and the evidence is 2B, which we'll go and discuss. So this is basically hypoglycemia. Hyperglycemia should be corrected. And the second one, the early ischemic changes, mild to moderate, other than frank hypodensity, which we discussed previously in the contraindication. With CT show hypodensity, which is explain the deficit, and it is more denser than opposite contralateral normal white matter. That is known as evolved infant. That is again, not that is the only thing that is contraindication. The extent of infarct they are not telling. Then coming to minor stroke, the thought of minor stroke comes when it is NHS is 0 to 5. In such scenario, what they tell is you have to consider how this is going to affect his daily activity and how it will going to affect his work. Suppose somebody who has a mild weakness of right hand, but loss of dexterity, but he is an artist, he is a painter, then it is going to affect his job. So you have to give individualized preference. The entire guidelines, it is basically more of individualized approach rather than a generalized approach. So that is one thing. And for this, they give certain ideas how to pick it. One is BATHE, bath. B for bathing, A for ambulation, T for toileting, H for hygiene, E for eating ability. If the deficit is going to affect any of this, then lies the patient. And you have to assess the ambulation and swallowing. So in the ER, if it is a minor stroke, you have to make him walk, you have to make him sip and drink something or eat something. Whether this disability is going to affect this, you have to lice. But you have to have a discussion with family, consider the age, everything, and then decide. And one more thing that they suggest is, if a hemianopia, aphasia, or attention, or any weakness, which score any of these four has at least 2 or more score in NIHS, a complete hemianopia, severe aphasia, severe hemiattention, which is at least 2 modality hemiattention, or any weakness more than or equal to 2 in NIHS, this also should be considered as disabling stroke. Disabling stroke is not just this, but this also should be considered. And you have to think that disabling stroke, whether this is going to affect his daily activities as well as his job. So individualized approach. So a complete hemianopia, severe aphasia, severe loss of at least 2 modalities, and a drift which go and hit the bed. If it is there, irrespective of NIHS, you should lyse the patient. That is a disabling stroke. Then what they tell is may not be clearly disabling, because suppose they mentioned mild, isolated mild aphasia. Suppose the patient is a anchor or a radio jockey. A mild aphasia may affect his job. So you can still consider disabling, discuss the patient and bystander, then decide. Isolate mild facial drop, mild cortical hand weakness, especially non-dominant, mild hemimotor loss, hemisensory, mild hemisensory motor, mild hemiataxia. But if ataxia is ambulation is affected, it is included as disabling stroke. So again, this is a very individualized approach. You have to think, first thing is you have to think whether it is going to affect his daily activity. Second is whether it is going to affect his job. If it is going to affect his job or daily activity, consider lysing. BATHE, bathing, ambulation, toileting, hygiene, and eating ability, if affected, should be lysed. Ambulation and swallowing should be assessed. Complete hemianopia, severe inattention, severe aphasia, or a weakness of more than 2 or more points in NIHS should be considered lysis. And now coming to thrombolytics. You have alteplase, which is there previously also, same dose, 0.9 milligram per kg, maximum 90. Tenalteplase is there, the dose is regularized, level 1 evidence up to 4.5 hours, 0.25 milligram per kg, maximum dose of 25 milligram. The new agents, which are retiplase and pro-urokinase, retiplase from the RACE trial, pro-urokinase from the PROS trial, the Chinese trials, and retiplase is actually a truncated form of alteplase only. And retiplase is given as 2 doses, 30 minutes apart. This also can be given as 2B evidence when compared to alteplase. That is a new intake. Then, a pediatric case, you can lyse, but only alteplase is approved. These are the thrombolytics. If you see 2019, there are only alteplase and a doubtful TNK. Now we have new molecules. So the next guidelines come, new molecules may come. So we are in, you have yet seen the initial trials, how fast it is progressing the last 3, 4, 5 years. So that is thrombolytics. So retiplase instead of alteplase, 2B evidence, IV mutant pro-urokinase 2B evidence, no benefit, desmotilase and IV mutant pro-urokinase combined with alteplase, and a urokinase less than 6 hours. Harm, not use streptokinase in less than 6 hours. So if MI with stroke, not use streptokinase, but you should lyse the stroke. So this is a pediatric lysis. Any patient 28 days to 18 years, confirmed ischemic stroke after MR, MRAngio, CT, CT, which we discussed previously, within 4.5% disabling deficit, you can lyse with 2B evidence. But the problem is they use PED-NIHS score. But again, less than 2 years, it is become a difficulty. So this is again evolving area. Is safe, but efficacy is uncertain is what they mention in 2B evidence. So pediatric lysis come up, but alteplase is only approved. So this is tenalteplase guidelines, other agents, retiplase, desmotilase, urokinase, streptokinase, and pediatric lysis. So basically lysis, disabling stroke, irrespective of NIHS aspects, you can lyse, if not contraindicated. Contraindication, remember the 10 things, 3 CT, 3 neurosurgery, 3 medical things, and 1 ARI. Then definition of disabling stroke, BATHE affecting ADLs or job has to be counted. Anopia, complete hemianopia, severe aphasia, severe extension or weakness more than or equal to 2 in an NHS score should be considered disabling, and individualized approach. Teneltiplase 0.25 milligram, other thrombolysis, retiplase and pro-urokinase, pediatric thrombolysis, but alteplase is only approved. So now we go to the another major part, extended window lysis. So before going to extended window lysis, you should understand this concept. Till that, we were chasing the time. So what we were doing was when a patient comes with a wake-up stroke, you will do an MRI diffusion flare. And if diffusion image abnormality start from 10 minutes or 15 minutes, whatever it may be. So it is the early change happens. So somebody who has a flare changes start appearing by around 4.5 hours. So somebody who has a diffusion positive, flare negative, that tells you that the onset is less than 4.5 hours. That was a concept. So you were chasing the time. You were continuously chasing the time. So we were lysing that. Now the concept has changed. Now we are looking into tissue rather than time. So the tissue, even if because of the collaterals, because the intrinsic factors, multiple mechanisms, even if it is 4.5 outside, there may be penumbra which are salvageable. So you do a perfusion image and you have to do use a automated software to find out calculate the mismatch. And if it fulfill the extend criteria, which is a trial which is done for this lysis in extended window, you can lyse the patient. So that is where the extended window happens. Treat the tissue, not just the clock. That is the idea of extended window. You are changing from time-based criteria to tissue-based criteria, which you were using previously in thrombectomies. So that is the shift has happened. So basically, this is extended window. When the stroke happened and patient came within 4.5 hours, you are going to lyse with normal protocol. But if it is outside 4.5 hours till 9 hours, according to guidelines, if it fulfill extend criteria with a penumbral imaging, that is a perfusion imaging, it is a CT or MRI, using an automated software, if it is there, you can lyse the patient. So that is the first 4.5 to 9 hour window, CT perfusion, MR perfusion, show enough penumbra, you can lyse. The second scenario, an LVO with 4.5 to 24 hour window. So first scenario is not for LVO, other cases. But if LVO within 4.5 to 24 hours, what usually you do is thrombectomy. But if because of some reason you cannot take the patient for EVT, like the patient is not fit or some other reasons, you cannot, or a failed EVT. In such scenario, you can do a diffusion perfusion and shows enough penumbra. There also you can offer lysis, but evidence is less to be. But the risk of bleed here to explain, but there is an option to give that. So that is how the extended window is now extended up to 24 hours, not just 9 hours. 24 hours can be done, but you have to understand one thing. Extended window outside 4.5 hours, right now, we are chasing the tissue, not time. So we don't have any evidence to use MRI diffusion flare mismatch outside 4.5 currently based on the guidelines. Practically, there are expert opinions, some people are doing, but what is there in the guidelines is this. Up to 4.5 MRI. After 4.5, you have to go with perfusion image. So you cannot lyse a patient outside window with MRI image only. You need additional imaging, and that needs a automated software, automated process, not a visual evidence. So that was extended window. Now going to wake up stroke. So wake up stroke here, the patient went to sleep by 11 p.m. So he has woken up by 4 a.m. So from 11, he went to sleep and he woke up by 4 a.m. That is 5 hours has crossed. You don't know the exact onset. So if he has woken up with a stroke at 2 hours, you can go with normal protocol, take a CT and lyse because it is just 3 hours from the last seen normal. Now here it is more than 5 hours. So you cannot use a normal protocol. And from wake up till 4.5 hours, from the wake up till 4.5 hours, from the wake up till 4.5 hours, you can use an MRI-based protocol, diffusion flare mismatch you see, and then lyse the patient. That is a classical wake up, which we are doing previously also. Now the new thing is, suppose a patient came to you in this window by around 9:30 or 10. What will you do? That is outside 4.5 window. There, you are going to do one thing. You have to calculate the midpoint of sleep. See, 11 o'clock he went to sleep. 4 a.m. he woke up. If the patient is coming after 4.5 hours from the wake up, then the next thing you should do is you should calculate the midpoint of sleep. Why you are calculating midpoint is, in the studies for wake up stroke in extended window, what they did was they had arbitrarily taken that the stroke was happened at the midpoint of sleep. So they arbitrarily taken it. So we are using the same study. So that is why you have to calculate midpoint of sleep. From midpoint of sleep, if it is 9 hours till the presentation. So midpoint is 1 a.m., 9 hours is 10 a.m. So midpoint since 1 a.m. to 10 a.m. in the morning, 9 hours from the midpoint of sleep, you can do a perfusion imaging and see the penumbra using an automated software, and you can analyze. That is a wake-up scenario change. So extended window has two protocols. One is wake-up, another is true extended. True extended we discussed, this is the wake-up. So wake up with the patient, wake up within 4.5 hours from the wake-up. A diffusion flare mismatch can be used. One important thing you should note here is, in a wake-up stroke, even there is a diffusion flare mismatch. If it is more than or equal to 1/3 of MCA, don't lyse. They are telling you can lyse only if it is less than 1/3 of MCA. The infarct should be less than 1/3 in a wake-up stroke. Other scenario, it is not there. And one more important change is the previous guideline, 2019, they tell that no flare changes. But now they are mentioning as no significant flare changes. Just to make it better understandable. So some flare changes is okay. But no significant flare changes should be there. And more importantly, less than 1/3 of MCA. And the patient is presenting from 4.5 hours to 9 hours or outside 4.5 hours from wake up. Then you need to calculate the midpoint of sleep. From the midpoint, take 9 hours. Within 9 hours, the patient presented, you can do perfusion. You cannot do diffusion here. You cannot do MRI here. You have to do a MRI perfusion or CT perfusion and automated software to see whether there's a penumbra, then you can analyze. Again, 2A evidence. So that was a wake up. And this is a wake up. You can see 1/3 of MCA, smaller than 1/3 of MCA is there. And no marked signal changes on flare. Extended window is there. So we discuss imaging, we discuss general management, we discuss contraindication of lysis, imaging and general management, the major changes in the BP, blood sugar, and some changes in oxygenation. Contraindication, only 10 things are there, the major contraindication. And recent stroke and recent bleed is not a contraindication. Then thrombolysis, minor stroke definition is there. Then thrombolysis, new agents are there. Extended window has been divided into two groups, wake up and other true extend. True extend up to 9 hours with diffusion, perfusion, basically with perfusion scan. And wake up, less than 4.5 hours from wake up, you can use MRI. After 4.5 hours, you should use your perfusion-based protocol. Now going to endovascular therapy. Endovascular therapy, you should see the evolution of endovascular therapy. In 2013, it was an era of EVT failure. IMS3, synthesis expansion, MR rescue, these trials has not proven any benefit of EVT. So it was a failed era of EVT. By 2015, it has changed to EVT became a standard of care within 6 hours. MR clean, escape, rescue, Rivascat, SIFT prime, all these trials came in this era and where it became a standard within 6 hours. Then came 2018-19, era of extended thrombectomy using Dawn and Diffuse trial, where we started doing thrombectomy up to 24 hours in the 2019 guidelines. Till that, we had two problems. One, we were not chasing basilar artery or posterior circulation. There was no proper studies. Then second thing was, we were doing only thrombectomy for a large core, small core, aspect more than 6. Aspects less than 6, we were not doing. Then came the era of posterior circulation and large core, where started with best and basic trial, which are the post-circulation trial, which is done in China, which are neutral trials. Then attention and Boschet, which showed beneficial effect of thrombectomy. Then a large core trial came, Angel aspect, Tesla, Select, and Laste, where the even aspect up to 0 were studied. And then they proved that even aspect up to 0 you can take for thrombectomy. The outcome is good. You may not need additional imaging also. So that is how the thrombectomy is evolving from a failed era to standard to extended thrombectomy to a large core and basilar artery thrombectomy era. That is how the EVT is evolving. The conceptual change happened because of the large core. The previously we consider core means whether it is in the diffusion or CT or a perfusion. If the core is there, it is irreversible as a concept. Now the concept has changed. The core doesn't mean it is completely irreversible. There is some amount of tissue, penumbral islands, which can be reversible. So that is a concept of large core thrombectomy. So the changes happened is window in anterior circulation is 24 hours with better evidence without much additional imaging. You can take lower aspects and poor MRS. Previously, the pre-stroke disability 0 to 1 was only taken. Now up to 4 can be taken. Basilar artery up to 24 hours can be taken. Medium vessel, we have better evidence by ESCAPE, MVO, and distal trials. Then tandem occlusion, we have better evidence. Pediatric thrombectomy up to 6. Above 6, we have better evidence. Below 6 also we can do. So we'll discuss into that. So basically, I am going to divide it into anterior circulation LVO, then medium vessel, then posterior circulation LVO. Then anterior circulation, I will be dividing into those with normal MRS, MRS 0 to 1, and poor MRS. We'll discuss first MRS 0 to 1. So MRS 0 to 1, all these, whether it is medium vessel, large vessel, or posterior circulation, NIHS should be more than or equal to 6. That is a basic entity. Less than 6, we don't have evidence. So if they present within 6-hour window, the classical window, Aspect 3 to 10. Previously, aspect has to be more than 6. Now, aspect 3 to 10, level 1 evidence. Even less than 3 in first 6 hours, you can take, but age should be less than 80. And CT, there should not be any significant mass effect. If mass effect is there, you don't need anything extra. You don't do that. But the evidence is 2A, reasonable. So anything above 3, best evidence. Below 3 in 6 hours, 2A. Then 6 to 24 hour window. Again, its MRS is 0 to 1. NIHS is more than or 6 without significant mass effect. Aspect 6 hour level 1. Up to 3 to 5 also you can take by level 1. But it has to be age below 80 and certain selected patient, which we'll discuss in the next slide. So basically, from 0 to 24 hours, aspects 3 above, you can take with level 1. Only there is a caveat in this time group within 3 to 6, less than 80. Otherwise, in general, above 3, majority of the patient you can take with a level 1 evidence up to 24 hours. Aspect 0 to 2, you have a risk of bleed is higher with 2 evidence only, again less than 80. So poor aspects, patient should be less than 80 and some selected patients. Why? Because this is a poor aspect study, angel aspects and last test study. Angel aspect, they are not included these patients. More than 80, renal failure, refractory hypertension, life expectancy less than 3. Similarly, last year has not taken more than 80, significant vessel tortuosity, suspicion of underlying intracranial stenosis. So these patients should be excluded when you are taking the lower aspect. So basically, in general, those patients up to 24 hours, if the aspects is 3 above, level 1 evidence you can take. Aspects less than 3, level 2A. But there is a caveat, like 6 to 24 hour window with an aspect of 3 to 5, 80 years less, and 80 and selected patient, level 1 only. So you can just remember, like up to 24 hours, aspect 3 to 10 you can take by level 1. And 0 to 2, it is level 2A. For MRS 0 to 1. So this is the last core studies, like Rescue Japan, Angel aspect, and you have Select 2 trial, Tension, Tesla last. You can see the odds ratio when it is more than 1. It is a positive study. Less than 1, not beneficial. You can see all the studies, it is a positive study. You can see the combined odds ratio also 1.5. So this is actually a large score has a better outcome, even with the normal imaging modality. So you may need to do a perfusion if you need in a very poor core like 0 to 2. Otherwise, you can take even above 3, usually with a CT angio. So that is the beauty of new guidelines. Then come to the poor MRS. We are discussing MRS 0 to 1. Now the MRS with poor, like MRS 2, you can take with level 2A. MRS 3 to 4, you can take by level 2B. But in a poor MRS, this has to be the classical criteria, like less than 6 hours, aspects more than or equal to 6, NIHS more than or equal to 6 has to be met. So poor MRS, it has to be less than 6 hours, aspects more than or equal to 6, NIHS more than or equal to 6. So that finishes the anterior circulation. So up to 6 hours, aspects 3 to 10, level 1, less than 3, level 2A, but age should be less than 80. 6 to 24 hour also, you can take aspects up to 3 to 10 at level 1. There is a small caveat, but you can take. And MRS 2, level 2A, MRS 3 to 4, level 2B, provided they present within 6 hours and aspects more than 6 and NIHS more than 2. So you have to look at MRS first, then you look at the aspect score and then decide. So this is a medium vessel occlusion. Medium vessel means distal to M1. So we discussed IC terminus and M1. Now this M1, M2 onwards, the M2 division is which lies over the insula. So what they tell is a proximal dominant M2 can be taken. So this proximal dominant M2 means, dominant means it is not left or right. It means that at M2 or insula, this MCA divides into superior division and inferior division. If this branch is going to supply 50% of the MCA territory, then that is dominant vessel. So dominant M2 is a vessel which supplies at least 50% of MCA. Then you can take for thrombectomy. But again, it has to be within 6 hours, NIHS more than or equal to 6, aspects more than or equal to 6, just like your MRS high stroke. So medium vessel indication is only for proximal dominant M2. Non-dominant, co-dominant M2, distal MCA, ACA, PCA, no benefit. So basically anterior circulation, you have only 3 vessels. One is M1, one is terminal ICA, third is a proximal dominant M2. And dominance is not left and right. So these are 3 vessels in anterior circulation you can take for thrombectomy based on the current data. Then coming to posterior circulation. Posterior circulation or basilar artery occlusion up to 24 hour window is excellent window is there. MR should be 0 to 1 and the PC aspect, posterior circulation aspect has to be taken and it should be more than or equal to 6. And if the NIHS is more than or equal to 10, level 1 evidence. NIHS 6 to 9, 2B evidence. So basilar artery with NaHS more than or equal to 10. You see in the anterior circulation, we're discussing NaHS more than or equal to 6. In posterior circulation, they discuss aspects, NaHS more than or equal to 10 as the best evidence. 6 to 9 also can be taken with the level of evidence of 2B within 24 hours. So that was about the posterior circulation. Now going to the pediatric stroke. Pediatric stroke, age more than 6 years, up to 24 hours. If LVO is there and salvageable penumbra is there, just like adult protocol, you can take with evidence of 2A. But if the patient age is less than 6, above 28, then you can take with a lesser evidence of 2B, can be taken with uncertain evidence. So that is why above 6 is the best evidence to do thrombectomy in a pediatric age group. Below 6 also you can do, but evidence is much less. So that was about the EVT. Basically, we discussed about large vessel aspect score based on MRS also. Now going to tandem occlusion. You have an ICA plus MCA. Previous 2019 was telling not a conclusive evidence. They are telling treating thrombectomy tandem occlusion is reasonable. But what they made it better now is, if you required, emergency stenting of ICA and MCA may be reasonable if required in emergency stenting, just not than the previous guideline. So tandem occlusion also, we have better outcome. You can stent it if needed in emergency setting. So EVT take home is up to 24 hours, a patient with aspects 3 or above, you can take with level 1 evidence, provided MRS is 0 to 1 and NaHS is more than or equal to 6. And selected cases of poor aspects less than 3 also can be taken with a level of evidence of 2A. And lower MRS with MRS 2 to 4 can be taken. Again, the level of evidence is less, but in a poor MRS, this has to be less than 6 hours. And in medium vessel occlusion, only dominant proximal M2. So there are 3 vessels: ICA terminus, M1, proximal dominant M2, which can be taken for thrombectomy. Other vessels you cannot take. Basilar artery occlusion also you can take for up to 24 hours. Tandem occlusion, you have better evidence to stent. And pediatric EVT, more than 6 years, better evidence, less than 6 to 28, evidence is 2B. So future which still remains unanswered in front of us is, one is outside 24 hours, lysis as well as thrombectomy. And other MVO and vertebral artery, NaHS less than 6 and MRS 5. MRS 5 is a bedridden patient. MRS 6 is a dead patient. So this we don't have an answer right now, which may come in the future. So this is a recommendation for EVT. And medium vessel occlusion, dominant M2, if it is more than 6 hours, within 6 hours, NaHS more than 6, aspects more than or equal to 6, and other vessels are not indicated. Posterior circulation stroke basilar artery you can take with the better evidence if it is NaHS more than 10. And pediatric stroke more than 6 as a better evidence, less than 6 years as a 2B evidence only. So that was a summary. We discussed about imaging in stroke, general management, contraindication, thrombolysis, extended window, and EVT. So imaging, door to image has changed to 25 minutes. Either CT or MRI can be taken. Suspected LVO, you should do an angio, which include intracranial plus cervical vessel. A pediatric cases, MRI is preferred more than CT. But if you cannot do within the time window, you can go with other imaging. CT imaging. Wake up and extend, you need to have outside 4.5 hours. You need to trace the tissue by doing a perfusion image using automated perfusion. EVT up to 24 hours you can take without any additional image, especially aspects more than 3. DTAS is a new direct triage to angiographic suite in LVO. Then take home in lysis, disabling stroke can be lysed. Any disabling stroke, they had given definition for disabling stroke. There's a change in contraindication, remaining that, remember the 10 things which are there in the contraindication. Tenalty place, we have better evidence. New thrombolytics discussed. Wake up and extended window up to 4.5 to 9 hours. LVO up to 24 hours can be taken if EVT is not possible. Pediatric stroke EVT and IVT guidelines are there. EVT guidelines we discussed. So that was about the practical update into this.
Great. Wonderful presentation, Dr. Baisak. You have, strategically analyzed each and every subdivision of the acute stroke thrombolysis guidelines. I don't think anybody will have any questions because you are pretty clear in how to approach each and every role we have discussed, starting from the imaging, the triage, the initial care, including oxygen, temperature, glucose, blood pressure, the thrombolysis, the contraindication, indication, the type of thrombolysis, the latest drugs available, and then the EVT, the indications in LVO, medium vessels, distal vessels, large core, and also the pediatric cases. It's wonderful. I think there are questions in the chat box too. we have 10 minutes. I think we can take the NOACs and thrombolysis, your approach.
NOACs and thrombolysis, if you have the facility to check the ECAR and transit all those time which test separate testers, and if you have reversible within 48 hours is last doses, you have to do that and then only you can lyse. If the last dose is prior to 48 hours, you can directly proceed lysis, but again you have to consider certain caveats, like those with poor RFT. They may have some delayed effect of the NOACs. So that scenario also you have to again ideally do those testers.
Correct. So the point is, as you have clearly told one line, in India it's very difficult to thrombolyze in NOACs because majority of the time we don't know these reversible agents are available in our center, and second is we don't know whether these testings are available. But okay, suppose if you are thrombolizing, which drug has more evidence, whether it is tenecteplase or alteplase?
So alteplase,
I don't think we have any data is have the evidence than tenecteplase. So better go with alteplase as in terms of pediatric population. So these are all the edge over tenecteplase in IVT trials. Okay, the second question in the chat box are, can we identify LVO clinically?
Yeah, LVO, you can, one is your race score, which I told you, more than 4. Then NHS score also, if it is more than 6, you can think it may be LVO. Then cortical signs, the presence of cortical signs, eye deviation, aphasia, or all those things suggest that, or even hemianopia, that is very classical for cortical. These things are there, you can think of cortical, more likelihood of a LVO.
Correct.
Just don't stick on to a score. You have to take the practical aspect.
True. So the basic thing is, as a clinical neurology teaching, whether you have a global aphasia and a dense hemiplegia with eye signs, it's ICA or dominant M1. Similarly, you have only Broca's aphasia, then no Wernicke's, then you know whether it is a branch occlusion. It's not a LVO, but with the codominant vessel in angiogram, you will decide. For posterior circulation, we will know the other signs also. So now we have discussed initially about the details like direct triage to angiography shoot. That is mainly for LVO. But the point is, how do we know there is an LVO clinically? But at the scenario, we don't have evidence for DTAS unless you have a tertiary care center which is capable of doing mechanical thrombectomy as soon as possible in the center. So the Indian Association Subsection stroke, we should not deviate from the protocols. Bridging is still safe in LVO, provided you can able to triage the patient, do thrombolysis as per the guidelines and absolute contraindications, and then shift the patient by a drip and shift to the nearest comprehensive stroke center for thrombectomy. Direct angiography shoot has advantage because the study says the outcome is much better, but when you are going to do a direct mothership program where you are directly shifting the patient from the ambulance to the comprehensive stroke center, it's better. Suppose if you are in a center where direct angiography shoot is not available in less than 120 minutes, that means 2 hours. So that means then shifting the patient beyond 2 hours to a direct angiography shoot is not advisable. This is what the guidelines, the latest guidelines are updated. But we have to take it as where you are, the geographical location, the expertise, the comprehensive team, and other things. So yes, clinically you can localize things. People are asking about experience with tirobefan. I think tirobefan is an absolute harm.
We have not used because actually in the guidelines they are not telling there is no benefit. But there are
till we have these guidelines, I think a lot of the interventionists will be there in this audience. They have been using it for strokes with progressing strokes or unstable plaques where with crescendo fluctuations, they've been using it post thrombolysis and even post thrombectomy also. There are takers for that. Yes,
and even
I think it is.
When you do after lysis, they may clot may lyse and embolize distal in a small vessels. They can give intraarterial also. They are doing.
True. So yeah, now we have intraarterial pro-urokinase and for the use, but yeah, so those things are still people are using, but there is no clear evidence. People are saying it is harm. Even the other adjunctive therapies like most of the studies like ergotraben, FTBF, the most study, as well as the latest other trials called MR clean medicine, where they tried along with tirobifen with heparin. They said that there is no benefit, more bleeding. So there is no evidence, but I think there are by case-to-case basis you can use or not, we don't know, but there are people who are using it across globally also. The evidence is not backing. Now, a stroke in pregnancy, like IVT, that's what the question they asked.
Yeah, stroke in pregnancy, the present guidelines, it is not a contraindication, it's a relative contraindication. You have to consider whether this is disabling stroke and severe stroke. Then you have to take obviously an opinion from the gynecologist. Then you can go ahead and license. That is what the guidelines say. But again, Indian scenario, in rural, it may be difficult to take a gynecology opinion, but there is not a contraindication.
True. So Dr. Deepak has asked about a very important question, relevant. It was mentioned in the summary that EVT up to 24 hours can be done without additional imaging. Can you elaborate, please?
Yeah, because there was some analysis which was done on the multiple trials, including Dawn Diffuse and the present trial. When they find out that the imaging selection doesn't matters much in the outcome. Then they came with the last day trial and the select 2 trial and those trials which do the large aspect or the large core trials. Then what they find out is that you have to look into the maybe the collaterals and whether there is an edema is there or not. Because whatever you are seeing is not exactly the actual core. They are actually tissue at risk. There may be some area of penumbral islands which are still salvageable. So that is why the odds ratio of all these studies in the Hermes analysis, which I showed you, the Hermes analysis of that shows that odds ratio is 1.5. That favors large core. And many of these trials, like Japanese trial, they used actually plain MRI only. And some of the trials, there are patients with CT angio. So that is what they taken that absolute recovery of perfusion is not enough right now. But those with the 2 aspects, less than 2, then you may consider doing.
True. So the question is, this is included in the recent guidelines because there are centers where you will not have an access to the additional imaging, including CT perfusion. So what is the basic imaging? Basic imaging is CT or MRI without angiogram. This is all basic imaging. So the study, I think, if I am not wrong, the TWIST trial, which has done only thrombolysis up to 24 hours with only CT and CTA. And there are no major bleeds and they have good outcome even after thrombolysis when they have selected patients. So what is the catch here is you have a subset of population where the NIHSS, there should be an LVO for thrombectomy and then there should be NIHSS more than 6 and the aspect should be more than 6. So these are all the population. Definitely we should not worry about going without any additional perfusion. But if you have, as we discussed before, the NHSS beyond 6 hours up to 24 hours, where the NHSS is aspects is less than 6, then you'll have more and more imaging data to understand the core and thrombolysis. So there are, the guidelines have included without additional imaging, but it is not level 1 recommendation. So we should be careful about that. So antiplatelet dosage in stroke guidelines. We didn't discuss about that. Yes. Any update?
The antiplatelet, there are multiple guidelines. Basically, those with minor stroke, you follow chance and point guidelines where you can load clopidogrel 300 milligram to 600 milligram, then continue with an aspirin of 75 milligram to 325 milligram. Otherwise, if there is no indication of dual, like if it is not a ICAD or not a minor stroke, or a high risk TAA, you can go with single antiplatelet. Aspirin is preferred. And the new guidelines actually include ticagrelor also can be used, but to be evidence.
True. So if you are thrombolizing the patient in the next 24 hours, dual antiplatelets are a relative contraindication. You start with single, whichever you prefer, then go for dual. Dual antiplatelets are only preferred if for a minor stroke or a TIA with or without LVO with the recurrent presenting symptoms. If you have an ICAD or a coexistent ICAD plus carotid occlusions, dual antiplatelets are used up to dual antiplatelets for 21 days, and then you can follow with single antiplatelets. Clopidogrel resistance, and then use the 2 trial now. Apart from the chance trial, we have INSPIRE's trial which backs up the dual antiplatelets, and the TALIS trial which backs up the use of ticagrelor versus clopidogrel. Yeah. There is one more question. Thrombolysis in patients with therapeutic dose of anticoagulation for acute coronary syndrome.
Yeah, if the patient is on heparin or warfarin, APTT, PTINR should be checked. And INR should be less than 1.7. Platelet should be more than 1 lakh. And APTT should be, I think, more than 45. Then you can go ahead with lysis. If it's more than that, you cannot go ahead with lysis.
So there is a question by Dr. Saif Professor Pasha. He has mentioned 72-year-old man with dense left hemiplegia with NHS of 17, BP of 190 by 95, CT no bleed, CTA monocclusion, last dose of rivaroxaban 8 hours ago. How do you approach? Risk factors: AF, diabetes, hypertension. 72-year-old man. Duration of stroke 2.5 hours. So whether go for thrombectomy, it's safer, right?
Yeah, go for thrombectomy is safer. Whenever you have some
Because
of the
monocclusion, you have
contraindication,
already proven. Yeah. And if you know that the platelet count or INR is less than 1.7, still you can take a chance, but last dose is less than 8 hours. So we are not sure about the.
And rivaroxaban, you need to have factor 10 level and all. That is practically impossible.
Not in India. Correct, I agree with you. If it is dabigatran, we can still think about it. Yeah. How do we access aspirin or clopidogrel resistance?
There are multiple ways. One is by doing genetic test, and second is buying the actual platelet function test. So ideally, this should be a platelet function test, because when the platelet is angry, even if it is when the platelet is acutely active, even if it is phenotypically it's not a homozygous mutation also, they will become more manifest. And again, some patients, even if there is no genetic resistance, you may see clopidogrel resistance in practically when you test. So ideal is actually platelet function test. But if you cannot do, at least you can, I mean, you can see the risk, particularly if you're planning to stent a patient who has high risk of multiple POVDs, multiple places. Then you can actually can do a clopidogrel resistance. If it is there, you can shift to ticagrelor.
Yeah, understood. So choice of DOAC, I think this is not within the purview of this topic, but still we can answer.
We can go ahead with any of this, but according to the trials, those who are elderly, like more than 75, apixaban is better option because lesser bleed. And the DOAC failure rate in the studies are more with less with apixaban.
Okay, but I think it's which depends upon the indication, whether it is in stroke prevention or prevention of bleeding, Has-blood score. All those things you have to take in consideration, including the Chadwick score, and then you take a call on drugs. But the efficacy and the bleeding risk are the one, and the comorbid profile are the one, and the age, all those things you have to consider. Yeah, it's a very good question. Ocular strokes, we didn't discuss about that. We didn't discuss about thrombolysis in sickle cell and CRAO.
Ocular stroke, basically what is a present guidelines, and there is a difference with what was there in the previous American Obstetric Society. I mean, American Ophthalmology Society, because what now tell is first thing is you have to confirm it is CRAO. Second thing is it has to be ischemic. It cannot be arteritic. That is if you are sure, because you see the fundus, if it is pale, which favors more of a arteritic, and if it is hemorrhagic, then it favors more of a embolic event. If you're confirmed, there is 2B evidence only. It's uncertain to give the benefits is uncertain right now.
True. So there is no clear evidence as of now. True. But it is okay to go thrombolysis in sickle cell. True. And regarding we have talked about BP management. So there is a patient where we call it as a lento progressor, which means the stroke which is progressing with good collaterals. Okay. So how do you manage the blood pressure? Do you allow permissive hypertension in these cases, or the guidelines? What do the guidelines say? The guidelines for during thrombolysis and thrombectomy we know, and 24 hours we know. But suppose we are not thrombolysing, we are not doing, there is no large vessel occlusion, but the stroke is progressing. So what is the mechanism, and how do we approach the positioning of the patient? How do we approach the BP management? Yeah.
Basically, first thing is you have to see what is the etiology. If it is a small vessel stroke like a lacunar syndrome, whatever you are giving may not be working just because of perfusion may not be working, because if the mechanism of lacunar stroke is totally different. But if it is an LVO, particularly if there's a stenosis, then it will be better to maintain a good perfusion by, I like to improve perfusion by keeping a higher BP. Then the head position, what they tell is no benefit no difference between 0 degree and 30 degree. So I will not keep more than 30 degree. I will keep around 20 degree to prevent aspiration also. I will not keep it flat also. But will not keep it upright, because practically many patients with especially stenosis, the acute scenario, when they stand up, when they walk, the perfusion change, they will have symptoms.
Yeah, correct. So if there is a possibility of worsening of neurological status like syncope and worsening of neurological signs like NHSS will drop, then you think that the stroke is progressing, but primarily it is because of the LVO and the carotid. So a lower level positioning improves the neurological outcome. So that is one pseudo progressor. And the second is BP is permissible up to higher levels, and even the latest guidelines also indicate not to aggressively reduce the BP medications after the INTRACT trial, but there is a permissive hypertension is also allowed. In fact, we can even induce hypertension also. That is also allowed when there is a lento progression. Is there any other comments from anybody? Is welcome on those gray zones, because we are just discussing the gray zones.
0.2 milligram per kg is also usually TNK 0.2 milligram per kg is actually approved by DGCA in India in 2016. Basically, the trials which is done in India, there is some trial about 3,000 patients and all, which is proven that's equally beneficial in India. But according to ACHA, it is basically 0.25 milligram per kg. Again, the difference is that what we are using is actually biosimilars, not the exact molecule.
True. So that's why we've been able to launch the 0.25 milligram of the other molecule,
No
in India. That is, So no definitive evidence of neuroprotection in stroke, except that ESCAPE NA trial which shows neritinide has some beneficial effect along with TNK in thrombolysis in LVO. Okay, now how do you balance the bleeding risk versus benefit in patients more than 80 years?
So what I will do is, one is I'll look at the MRI. If the cortical microbleeds, especially if it is cortical, if it is more than 10, they will have higher risk of bleed. Second is background of multiple risk factors like previous stroke, hypertension, and coexisting small vessel disease like hypertension plus a diabetes, or a previous history of bleed. These things add on, and present BP is high, or other coagulation problems. These things will add on to, that is why you have to consider the risk versus benefit.
So blood pressure, sugar, extensive white matter changes, microbleeds, and the present core, all those things, NHSS aspects, all those things decides your clinical decision at that point of time. We have discussed. Yeah, you can take
identify if M2 is dominant or not.
Yeah,
this is your M1 is a horizontal segment. Then M2 enters into the insula. Inside that, M2 divides into two branches, superior division and inferior division. So this is going to supply your MCA. So if the branch is occluded, if it is supplying at least 50% of MCA, then that is known as a dominant M2. And one more thing is, this proximal M2 means from the bifurcation should be between 1 centimeter. That is what trials tell. Then also, if it is supplying at least 50% of the MCA, you will call it as dominant MCA, dominant M2.
There is a definition for that. True, I agree. So we discussed about area, amyloid imaging, related imaging abnormalities. So it's gonna come in the next 1 or 2 months. It's a reality. So what we as a stroke neurologist should be careful about area, and how do you choose those patients?
Amyloid related imaging abnormalities, better not to lyse because they have high risk of bleed. Second thing is they can have a spectrum of carry. So carry-like spectrum, they usually will have vasogenic edema instead of cytotoxic edema. They will have diffusion as well as ADC hyperintense, and you will see flare edema. Such patients usually respond to steroid also.
True. So the sometimes the edema presentation of the drugs related abnormalities can behave like a neurological presentation of a stroke. So we should not think about a stroke, because sometimes you have to differentiate with this area related edema, where it, as rightly pointed out, can be response to either stopping the drug temporarily or increasing the interval, or you go ahead with edema management like steroids, not thrombolysis. So thrombolysis is an absolute contraindication as of now, because of this amyloid vasculopathy has the more chances of bleeding per se, because of the vascular friability and lots of inflammation associated with the amyloid can induce the inflammation cascade also. So that's why even in large vessel occlusion, thrombolysis is not safe during amyloid-related strokes.
One more
Any other
question.
questions?
Somebody asked that antiplatelet drug prior to thrombolysis given in PHC. So, if you go into the guidelines, what they tell you is in single antiplatelet and dual antiplatelet carries a slight risk, but the risk for a single antiplatelet is less than 1%, almost 0.9, and dual antiplatelet is 1.2%. So that is very, very negligible risk. So you can take for lysis, no contraindication.
No. So antiplatelets not a contraindication. Transient global amnesia presenting in window, how can we show that it is not a stroke? MRI can be negative initially, lysis in such.
So transient global amnesia is a syndrome of pure amnesia. They don't have weakness. They don't have any other thing. They will even identify everything except that they have the event-related amnesia just prior to that and after that. So symptomatically, it is totally different entity. The diagnosis is different. There is no confusion per se. Hello? Hello, am I audible, sir?
This is not there.
Yeah, I'm audible. Yes.
Heparin in stroke management, anticoagulations are recommended only in cardioembolic stroke, and also you can use the 2B evidence for preventing DVT. Otherwise, heparin has no specific role. Even another scenarios where you can use anticoagulation is if you have a dissection. Up to 3 months, either anticoagulation or antiplatelet, that can be given.
Yeah. So that again is a very gray zone. So how about the discussion about low cardiac ejection fraction? I don't think this is not in these guidelines. I think when there is a dilated cardiomyopathy, when there is left ventricular thrombus, I think there is a role for, I don't know the current clinical evidence about anticoagulation in that scenario.
And decompressive surgery guideline. Decompressive surgery, there are two things. First is what they tell is a two-way evidence is there for those who have a worsening, even the sensorium. If it can be explainable by the edema, you can consider doing. Second is those less than 60 years in MCA infarct, less than 60 years in the first 48 hours, there is a clinical deterioration despite medical management, secondary to edema, you should do it. Best evidence, level 1. And then a posterior circulation, especially cerebellum, if it is more than 35 ml, or if it causes brainstem compression, or if it is worsening hydrocephalus. If hydrocephalus, ventriculostomy plus minus suboccipital craniotomy. If it is a cerebellar edema, if the cerebral volume of infarct is more than 35 ml, or if it is causing midbrain compression or brainstem compression, you can consider doing a suboccipital craniotomy.
Yes. Acute MI and stroke, which thrombolytic agent? We have discussed here. So if there is a anterior STEMI, which LAD block with STEMI, better not to avoid thrombolysis. Go ahead with thrombectomy. Cardioembolic stroke after thrombolysis, single antiplatelet or NOACs or both.
Yeah, again, the starting anticoagulation post cardioembolism or cardioembolic stroke. Previously, what we followed is a mild stroke, which can be either NIHS based or volume of the stroke based. NIHS less than either volume less than 2 centimeter cube. You can start with 3 day, then 6th day and 12th day. But the present guidelines tell early initiation can be useful within 48 hours. Also can be useful if it is very mild. So practically what we can do is you consider the NIHS as well as the volume of the stroke. If the volume of the stroke is say less than 2, you will call it as mild. 2 to 30, you can call it as moderate. If it is more than 30 ml, you can call it as severe. For NIHS, less than it is mild, 8 to 16 is moderate, more than 16 is severe. So 0, 3, 6 and 12 was the previous what we were following. So 0 is for TIA, 3 is for mild, and 6 is for moderate, and 12 is for severe. So in these days, 0, 3, 12 and 6, you have to take a CT. If there is no hemorrhagic concern, you can start. That is my idea, sir. So any take on this, sir?
Yeah. So that's when to start anticoagulation was the question. But the question here is after cardioembolic, why do you want to start antiplatelets? I'm not getting your point, because once you are starting anticoagulation is more than enough, unless there is a compelling indication for antiplatelets, like I think coronary artery disease produced a cardioembolic stroke, or something like a stenting recently. Is there is a need for antiplatelets? Otherwise, you can strictly continue anticoagulation. Antiplatelets along with anticoagulation can be given for a selected period of time. Cardiology is used for one year, but we don't have any clear evidence for neurology stroke prevention. But you can use it either with aspirin along with anticoagulation. Dual antiplatelets with anticoagulation is a big no. I think it's very good. We have discussed everything. The questions keep coming because it's a big, passionate territory of management in stroke. Patient with PCA stroke with basilar artery occlusion scan, can we check mismatch ratio and lies? If presenting at
the
posterior
problem,
circulation of the perfusion mismatch. I don't.
posterior, the problem of perfusion is two things. One is it can have difficulty in doing posterior circulation. There's a lot of artifact posterior circulation perfusion is almost impossible to do. Second thing is if they have a RFT dysfunction and in pediatric patient as well as those with the proximal stenosis, perfusion may not be completely correct also. There are some problem with the perfusion in that area, but in basilar artery, I don't think perfusion will be useful. You have to go with classical NHS because that is a window is up to 24 hours.
Yeah. So true. So I think post CABG can be given IVT.
Stroke after recent CABG.
Contraindication. Up to 14 days, 2 weeks contraindicated.
Present actually surgery up to 10 days. Then after then you have to discuss again. It's not absolute content. You have to discuss with the corresponding team and decide. But most of the time they will not allow you to thrombolyze within 10 days or 14 days.
Yeah, but not all CABG are a minor CABG. Some are like catastrophic CABG. So you have to discuss with the cardiothoracic surgeons whether thrombolysis is safe, because sometimes there is a risk of cardiac tamponade, pericardial rupture and all. But better if it is a large vessel occlusion proven, you go ahead with thrombectomy. That's always the safest option.
Acute MI with stroke, any either altiplase or altiplase, both can be used.
I don't think is there any research on that. The question is so tricky. I think you can use both. I don't. This is primarily, as we discussed, a non-STEMI MI and not including the anterior division of LAD. Yeah. Correctly placed dose in MI. Are we aware of that?
0.4, 0.4, I think so.
I think so, yes. Okay, so shall we? It's a very great discussions. I think you are completely thorough with everything. People are bombarding with so many questions. The pathophysiology, the science, the mechanism, the guidelines, the evidence, rare gray scenarios, everything. So it's wonderful to be inviting you as a speaker here, Dr. Paisak. It's a pleasure. Over to you, Prabhas.
Thank you, Prabhas sir, and sir, I'm very thankful to giving me this opportunity to have a presentation.
Yeah, so you did wonderfully well. I think we've been learned a lot, all of us. Very good. Yeah, thank you.
Thank you, Dr.
Prabhas.
Baishak. Yeah, thank you, Dr. Baishak. It was a good presentation and lucid discussion. And watch out for the space. We have lined up 5 talks, and it'll be really interesting. Next 2 months, we'll be getting you with good innovative talks. Thank you all.
Thank you.
Thank you, sir, and thank you all.